A lot of promising research is being conducted in ovarian cancer, and it's likely that the introduction of novel non-platinum-based chemotherapies and molecular targeted therapies will have a major impact, especially in treating recurrent disease. Mike, what are the most promising emerging agents for the treatment of ovarian cancer?
Well, Maura, I can think of at least four general class of compounds which are interesting both from a molecular standpoint and from early clinical trials. One would be the PARP inhibitors, which we will talk about in a second. They're particularly, look like they're particularly valuable in patients with BRCA1 and 2 mutated tumors. The second class we've touched on a little bit, which is the anti-angiogenic agents. So there's no doubt that there's a signal, I think, in ovarian cancer that it's a tumor that's exquisitely sensitive to anti-angiogenic agents. And bevacizumab, of course, has been tested the most. But you should be aware that certainly TKIs like pazopanib and cediranib have shown some interesting activity, I think trading off with a lot more toxicity, in my view. But nevertheless, although the pazopanib trial was positive, it looks like the company's not going to develop that drug, but cediranib is still being considered for further development. There are also interesting targets, other targets like Ang2, for which there's several active agents and some phase 2 and phase 3 data suggesting activity. And then others in earlier development would be something like delta-like ligand 4, which is in the Notch pathway. These are all targets within the angiogenic field for which there are drugs in development, so we'd keep our eye on those. The third class is antibody drug conjugates. There are a number of very interesting proteins that sit on the surface of ovarian cancer cells and essentially nowhere else in the body, which can be targeted by antibodies, and these antibodies are linked to very powerful chemotherapy agents. So a couple examples on this would be an Imunogen drug which targets the folate receptor. Now the folate receptor, I think, is a very promising target, although the recent trial was negative. I think that was more of a problem of imaging and the particular conjugate they were using. Another example for the audience to keep in mind would be MUC16 and also NaPi2b, which is a phosphotransferase that's on the surface of ovarian cancer cells. And so all of these conjugates are into at least phase 1s, if not phase 2s. They have limited toxicity and are beginning to show some activity. And then the final group of agents I would bring up, because it's certainly a hot topic, is immunotherapy. So PD-1 and PD-L1 are now entering into clinical trials in ovarian cancer. There's a lot of excitement. Work done from University of Pennsylvania, Bob's institution, showed that ovarian cancer can be manipulated in a positive way by immunotherapeutic approaches. And so I think that's going to be quite exciting.
So what about PARP inhibitors?
Well, PARP's an interesting story. As you know, the science on that dates back several years ago. It's a very elegant story coming out of labs, particularly in the UK, showing that the inhibition of PARP protein can inhibit the repair of single-stranded breaks, leading to double-stranded breaks, and double-stranded breaks are lethal if you don't have a functional BRCA1 and 2 protein, hence synthetic lethality. That laboratory observation was migrated into the clinic with really spectacular early results, showing, I think, fairly high response rates in the 30 to 40% range in tumors that had mutated BRCA1 and 2, even in the resistant setting, probably not in the refractory setting. The story, some of the early trials were probably not designed completely correctly, and so a couple years ago, many of the companies began to back away from the development of these drugs, and we were all very disappointed with that. But just recently, over the last year or two, everybody's come back into the field, and now I believe there are no less than 5 registration trials using olaparib, rucaparib, niraparib, and even filaparib, which are the 4 PARPs that are furthest along, exploring them in mostly BRCA mutated patient populations, though some of them are also looking at platinum sensitive. And they're looking at them both in treatment and in maintenance strategies. So my prediction would be that you'll probably see a PARP inhibitor approved for the use in ovarian cancer patients, probably in the mutated population, within hopefully 2 years.
Is there any rhyme or reason for, in combination with a cytotoxic agent or as single agent therapy?
It's a great question. It's almost like a religious question because there are believers and non-believers. So the non-believers will tell you that what PARP is really doing is impeding the repair of breaks in the DNA, and that's what your cytotoxic is doing. And so it doesn't make a lot of sense adding them together. You're just going to get more toxicity without the advantage. On the other hand, if you give a platinum and you cause single-stranded breaks and then you block the ability of the cell to repair itself, you may get some synergistic activity. I don't think we know the answer, Bob. We do know they're not easy to combine. The one exception is Olaparib is probably the best. There is a lot of myelosuppression when you combine the two. And then it's sort of hanging out in the background there is the issue of long-term toxicity. We're all a little worried about giving drugs that inhibit DNA repair, particularly in combination with chemo, to ladies who then may live 6-7 years. Are they going to show up with MDS or leukemia?
So in this setting, that's a concern because we obviously have that experience with the alkylating agents and radiation in the past. So again, you said there's no answer to it. At this point, is that something that, from a doctor-patient perspective, when one of these drugs gets approved, is that something that should be discussed, or is it we just don't have any evidence today? How would you approach that?
It's a good question. I think if it gets approved, that it'll likely be approved as a single agent, not in combination with chemotherapy. And it'll probably be later in the course of the disease, either in first remission maintenance, potentially even second or third line as a single agent. And there, of course, your risk of long-term toxicity may be somewhat diminished. But I think, to be fair, you'll need to discuss all of that with your patients, both short-term risks and long-term risks.
Fair enough. Any other questions or comments? Obviously, there is some really exciting research ongoing, and we'll have to wait for the results.
Mike, quick question. Do you have any thoughts on identifying a marker for bevacizumab specifically in women? Like that kind of research?
I have lots of thoughts, Warner. So actually, that is probably the second holy grail, other than the PARP inhibitor, which is if we have a PFS difference but not an OS difference, could we identify a subset of patients who benefit the most? And that, of course, then might translate into an OS. I'm not even sure that's true, but I do suspect, and Bob may want to comment on this, that there are patients for whom Bev is better than other patients. And to date, other than the more recent presentation at ASCO by the Scottish group, it's been very difficult, even in other tumors, to identify either plasma-based markers or tumor-based markers to identify patients who are going to benefit the most from an agent like bevacizumab. The reason for that may simply be that angiogenesis is so complex that no single marker is going to do it. We're going to need to understand the process a little better.
I don't have anything to add, but I think that your points are very well taken, and I agree with them.
What do you think about the ASCO presentation that suggested that they had identified a pattern that would separate patients into those that would and would not benefit?
Yeah, so I had the pleasure of debating Charlie about 4 weeks ago over in Frankfurt, and I saw that data, and then he presented additional data that they've obtained since then. And so, to be fair, because they're a very good group of scientists, I think we ought to just recognize that it is based on a very small number of specimens. It's not been validated. You know, it's a pretty complex bioinformatic analysis. And so it always worries me that when you need to do that to identify a subset of patients, that you're going to get a false positive signal. So I don't believe it until we obtain independent validation, which frankly the GOG 218 specimens may be a good source.